and then the orange arrow. Okay, and then click on your slide. All right, you're good to go. Thank you, sir.
All right, ketamine. This is a lecture that I just gave in January to the integrated medic meeting, the medics, Spokane County medics. So there is some local county protocol that I'll probably just quickly go over and not spend a whole lot of time on because I don't want to teach the local protocol. But this is a drug. You guys using it in Poland? Okay. And I know Kootenai, who's here from Kootenai? Kootenai's using it, has been using it successfully. We've been a little slow on adopting ketamine in Spokane County. It's taken a big push. We finally got some approval to get it in place. It is a great drug. It has a time and a place that are appropriate for use, and it's not every patient, okay? So we're going to go across what it does, how it works, and when it's best utilized, okay? So pharmacology, history and past experience. We'll talk about indications, and then we'll get into contraindications. So ketamine, Ketalar is the trade name. It's an NMDA receptor antagonist that binds at the PCP binding site. So you'll frequently see a positive tox screen on people that have had ketamine. They'll come back positive for PCP. It's a dissociative anesthetic and analgesic. So it's kind of an out-of-body experience is what people describe. So it's not technically a sedative. It's not conscious sedation as much as it is a dissociative agent, okay? It's a hepatic metabolism, so metabolized extensively in first-pass metabolism. So I eat it, absorb it, inject it, whatever. I'm going to cycle and make a it exists and gets converted into a more active form through the liver, and then it's renally excreted. The half-life is about 2.5 to 3 hours. It's a Schedule III drug. It's available in 10 milligram per milliliter, 50 milligram per milliliter, and 100 milligram per milliliter concentrations. This one is hard to get. What are your guys, 50? 50? Yeah, 50? Yeah. Vast majority of people have 50 milligrams per milliliter. That'll have relevance in just a bit. We'll talk about that. It blocks calcium influx at the NMDA receptor, blocking sensory input and limbic function. So it takes out the cortical processing of sensory information. It's got moderate influence on the opioid receptor, the mu receptor, and that contributes to some of its analgesic and euphoric effects. It inhibits the reuptake of norepinephrine and serotonin on embryologic tissue. So it hasn't been studied formally in live patients as showing this, but they think that this is why it has some benefit on patients with depression. So you'll see ketamine clinics popping up where people with depression go in and get ketamine infusions. And there's some evidence to suggest that it has a very positive, about 3-month effect on people with depression. You get a ketamine infusion, they're good for 3 months. It's like we used to do electroconvulsive therapy, you know, put the bite block in, shock their brain, their depression was gone for 3-4 months. Okay, you ever saw One Flew Over the Cuckoo's Nest? That's like the Hollywood version of electric shock therapy. It's actually a very beneficial treatment for people with severe refractory depression. Okay.
Electric shock therapy is.
Electric shock therapy, yes. And it's still utilized.
Just sounds like torture.
It's like so is cardioversion. I mean, technically, you cardiovert people and defibrillate people all the time, right? It saves their life, treats them well. They walk up and get away and do fine. Same thing with electric shock therapy, as long as it's not punitive, disciplinary, like in One Flew Over the Cuckoo's Nest, and they're not getting it every 6 hours, right? So the dissociative anesthesia, the exact mechanism is unclear. It's thought to selectively anesthetize the limbic system, preventing sensory input, but you preserve brainstem function. And this is where it's found favor in pre-hospital and emergency care, is that I can preserve a cough, swallow, corneal reflexes, and I can preserve respiratory drive, right? That's where your benefit is at, is that I don't have to take away these reflexes, these protective, vital brainstem reflexes that keep people functional. The metabolite, norketamine and hydroxynorketamine, have analgesic properties which are significantly longer lasting than the anesthetic properties. So it's an effective analgesic and requires sub-analgesic dose or sub-anesthetic dosing to achieve anesthesia or analgesia. So I can use it for pain at a significantly reduced dose. It'll last longer for pain than it does for sedation or dissociation. Okay, does that make sense? So it's got a couple of properties to it that are very effective. It can be given intravenously at 1.5 to 2 milligrams per kilogram for analgesia and 0.1 to 0.2 for analgesia. So anesthesia, sedation, analgesia, pain. Onset within a minute, duration about 5 to 10 minutes, although analgesia lasts longer. If I give it intramuscular, it's 4 to 5 milligrams per kilogram. Onset is 5 minutes, duration about 20 to 30 minutes. Okay?
Is the analgesia properties in the protocol for Spokane?
Yeah. So what are my clinical effects? It induces an anesthesia state referred to as the dissociative state, which is trance-like. You can get, eyes will remain open. Often you'll get what's called rotary nystagmus, where they'll be eyes will kind of be doing this sort of thing, kind of looking around. And sometimes you have to tell family, hey, you might see their eyes still open and moving around, but they're out, okay? Cough, swallow, corneal, all are intact. There's some amnestic properties, but they're less than that observed with benzodiazepines. Has limited effect on the pulmonary system, but there is some bronchial smooth muscle relaxation, which some people have advocated for its use with intubating asthmatics, is that you get a little bit of bronchodilation, which can benefit you in those people who are clamped down. Cardiovascular side effects, you're going to get a little bit of a central sympathetic surge, so a centrally mediated, CNS-mediated sympathetic surge, so you'll have an increase in heart rate, increase in cardiac output, and an increase in blood pressure. These can be relatively contraindicated in somebody who's experiencing myocardial ischemia or sensitive to increases in myocardial oxygen demand. So this is probably not the best drug for somebody who is in cardiogenic shock. If I have a cardiac arrest patient that I want to intubate and I see a STEMI, this probably is not the best drug for them, okay? Because there are some things that can cause an increase in myocardial oxygen demand. Adverse reactions, the reason that this has found some limited popularity in the past is because of the side effect profile is pretty extensive. You can get what's called an emergence syndrome, where people kind of have nightmares when they come out of the drug. It's more common in adults than peds, and it's about 10 to 30% of people. It can last several hours, but it responds exceptionally well to benzodiazepines. So if you give somebody ketamine, you can give them a little benzodiazepine afterwards to facilitate kind of a nice emergence as opposed to a nightmare emergence. How often have you seen this emergence phenomenon in your use?
We always get benzos.
Yeah. Okay.
I've only seen the hallucination part of it.
Okay.
Well, we give it to them.
So they're kind of like,
Yeah.
like they're at a rave or something. That's why it's a rave drug, Special K, right? So everybody used to break into veterinary clinics to get the ketamine. Excessive salivation can be a problem. Laryngospasm can be a problem. It does cause increase in intraocular pressure. You can have some vomiting, which actually rates are higher with IM administration than IV administration. And if you push it fast, you can have respiratory apnea. And they don't know why it is. It's not your typical respiratory drive effect. It's kind of like a shock state, like a shock to the respiratory system. And I'm not sure the exact pathophysiology behind it, but people are just like, stop breathing. But it's not like a slow respiratory drive like you get with opiates and benzos. It's like, done breathing, okay? But that's only when it's administered fast. So you have to do a slow administration IV, okay? Make sense? Increased intracranial pressure is well documented with the use of ketamine. You can increase intracranial pressure. It's related to cerebral vasodilation and subsequent increase in cerebral perfusion. It used to be contraindicated in patients with neurotrauma, but there are several really good, valid studies that have demonstrated that it does not cause adverse effect in this population and can be used in the setting of neurotrauma. That it doesn't translate to an adverse clinical event, okay? But we should use it with caution in people with hydrocephalus, a kid who's altered and seizing who has a shunt. Probably is not the best drug in a kid who's shunted or somebody else who's shunted. Okay, does that make sense? You know what shunting is, the VP shunt, they got the little thing, the tubing, families know about it. I got a kid who's really sick. I think he's got meningitis. He's really tanking. You know, then I got to be like, all right, well, how is the best route of administration, or what's the best drug for this case? This might be someone who I would avoid ketamine in. Okay. The history, it was developed in 1962 at Wayne State University. Short duration made it a very favorable dissociative agent. It was approved for use in 1970. It was introduced as an anesthetic to American soldiers during the Vietnam War. In the 70s, they started to see people use it extensively in psychiatric and academic literature. It's describing a state called ketamine intoxication. And since that time, particularly in the 90s and into the 20th century, as rave and club scenes became more popular, it gained popularity as a oral drug that people could take, usually referred to as Special K. It's still commonly used in pediatrics as an analgesic and anesthetic for brief procedures that require sedation. I used it all the time in kids when I had to do sutures, take stuff out of their nose, take stuff out of their ears. Very, very favorable side effect profile in children. But that emergence phenomenon really limited its use in adults. And I think was probably more, it was more of such a violent response to the drug that it probably gained more credibility than it deserved as a drug that caused adverse effect, because the number, what we were told in residency is, yeah, if you give it to adults, they have nightmares. And that's really not the case. It's a smaller percentage. It's still there, but it's easily managed and not as common as dogma would suggest. So we saw early 2000s, we saw an increasing use in the emergency care setting, and it's really been found as a very popular drug in the pre-hospital setting. So your general indications are going to be for excited delirium syndrome, induction for endotracheal intubation, and analgesia. Okay. Excited delirium syndrome is an altered mental state with combativeness and aggressiveness, most often associated with sympathomimetic drug use, cocaine and methamphetamine. You've seen this person before. You've given them all the Versed you had. They're still crazy, still dangerous. That's why we got ketamine, okay? And that was really why we got it, because you can give a guy who's tweaked out 10 milligrams of Versed and they'll still be tweaked out and dangerous, okay? You can give them ketamine and they stop tweaking.
So should we try using benzos first?
No. I use ketamine first. That was me. And I've started using it more in my clinical practice before we started adopting, as we started discussions about bringing in the pre-hospital setting, because I was not using it in adults. So I started using it in adults so I could formulate a position on it, essentially. It's like, well, I need to know if I like this drug or I don't like this drug, because I don't use it enough to develop an opinion. So if you came into the ER and you were annoying or screaming or obnoxious or violent, guess what? You're part of my experiment. You got ketamine, right? And it was very appropriate because these are people that I would have sedated with a more traditional means of benzodiazepines, Haldols, like Prexa, some other agent, right? They were going to receive it anyways. Instead, I adopted the use of ketamine. And I found that it was extremely favorable in onset. Could be easily followed by benzodiazepines. They need to be monitored. They need to be on cardiopulmonary monitoring when you utilize it. But I was able to get an IV in, get at least a liter of fluid in before they woke up, which most of these tweakers need, right? Get a urine catheter in to collect the urine specimen that I need to work them up, get a blood draw safely, right? Because the last thing I want is nurses in there with IVs trying to poke a guy who's violent. So we just let him go to sleep. And you get your IVs, catheter, bada bing, right? We have to recognize that excited delirium syndrome. These folks are at risk for sudden death. 8%. You've seen this in the news quite a bit. People who have been wrestling with the cops, etc. And usually this precipitates sudden death, right? So excited delirium syndrome with a conflict, and then all of a sudden the guy's dead. We've seen it in the news. We've seen it in Spokane, unfortunately. Just be careful because there's a lot of things that can cause an excited delirium type syndrome. Hypoglycemia, thyroid storm, temporal lobe seizures. A lot of things can do this, okay? And certain psychiatric conditions like schizophrenia without the use of sympathomimetics can precipitate an excited delirium syndrome also. Pre-hospital potential features, we see pain and excessive or an incredible pain tolerance is seen in almost universally across the board. Tachypnea, rapid breathing, sweating, agitation, tactile hyperthermia, non-compliance, lack of fatiguing, unusual strength. I mean, this is like the Hulk, right? So when you get the Hulk and you're like, man, this guy just doesn't stop, that's excited delirium syndrome. Mirror glass attraction, this is my favorite one. In front of mirrors, like looking at stuff in front of mirrors, looking at their, I was joking in my lecture, I think my kids all have excited delirium syndrome. I might have had it a time or two. No one's looking. Mirror glass attraction. I think we all got a little bit of that. Don't pretend like you never know it. Superhuman straight, right? AutoZim. You guys remember AutoZim? Heard the name AutoZim? Right? So this is a schizophrenic guy who lived in Spokane, who was unmedicated. Was known to be non-compliant on his meds, was somewhat disorganized in thought. A couple of people driving by called the police and said there's a suspicious guy. We think he's breaking into cars. The police showed up at a gas station, confronted him. He's obviously disorganized and schizophrenic, and was resistant, got into a conflict. He got wrestled to the ground. He was restrained and he died. And he ended up with excited delirium syndrome. His drug screen was absolutely clear of methamphetamine, cocaine, any sympathomimetic. Okay? But it turned into a big deal in Spokane as a result. So what's the pathophysiology of excited delirium syndrome? It's unclear, but it's thought to be related to CNS and dopamine dysregulation. So chronic abusers of drugs, cocaine, methamphetamine, are more likely to suffer from excited delirium syndrome. It's not usually your one-time user. It's somebody who's chronically dysregulated, who's more susceptible to the effects. But the dopamine hypothesis lends credence to why it can be with people with just pure schizophrenic, because they're dopamine dysregulated. That's part of the disease process. It does not appear to be a dose-related phenomenon. It's not because I just did a ton of meth. Right? It's not because I did like 5 lines of Coke instead of 1 line of Coke. Okay? It's an unrelated to dose. Most fatalities are attributed to severe acidosis. Most occur right after a violent struggle. It's usually a Brady asystole PEA phenomenon from severe acid, so my H's and T's. Hydrogen ion acidosis, severe lactic acidosis is generally what it is. The pH is so low that their heart just says, I'm done. It's not typically dysrhythmia related. It's not something that you can shock them out of. It's typically a Brady PEA to asystole phenomenon, okay? And the hydrogen ion of my H's and T's. This has been described extensively in the veterinary literature of animals that were captured. They would go ballistic in a cage, and then they would just die. And it was called capture myopathy. And they had severe acidosis, rhabdomyolysis, and they would resist capture, and then they would just die. So it was described in the veterinary literature early on. What's our treatment? One, you need to have law enforcement participation. The vast majority of the time, they will be involved with these folks because it's some sort of criminal behavior that elicits a 911 call, or bizarre behavior. Naked guy keeps staring at him in the glass in front of the mirror in downtown Spokane, right? Doing the dance there and ballistic. Not making sense. That's going to get police called to the scene. You're going to get called there also. The first treatment sedatives, including ketamine and benzodiazepines, to facilitate safe treatment. Hyperthermia, documentation of temperature is critical in these folks. They will be hyperthermic. Twice now, 2 times in the last 2 hours, you've heard to take temperatures on sick people. Take the damn temperatures, okay? It's valuable information. Valuable information. Cold saline infusion, external cooling measures, sometimes just taking clothes off of them. Maybe they're already unclothed. It'd be great, right? And misting them. Taking a wet rag, taking a moist cloth and getting them wet and exposed. Sometimes the fastest way to cool people down, okay? They need large volume resuscitation for their acidosis. What do we give people who are acidotic with rhabdomyolysis? Lots of fluids. We don't give them bicarb as our first line of therapy. We give them saline as our first line of therapy, okay? Cardiac arrest, standard ACL efforts, but if I had someone who's sudden cardiac arrest, I generally am not an advocate of early bicarb in people, but we know that excited delirium arrests, hydrogen ion acidosis, severe acidosis, I would treat early with bicarb. It's one of the few examples of where I would give bicarb early in a cardiac arrest, okay?
Earlier, as far as like starting with Brentard, starting moving towards that.
Some people advocate that, but I think it distracts from aggressive volume resuscitation as your primary beneficial treatment. And if they go or they are going or they're now severely bradycardic hypotensive, then you could consider it. I think it's reasonable. But I wouldn't do it pre-fluid.
Yeah. When we get the arrests on this, we need to stick with the epinephrine, or are they already amped up on so much epinephrine?
I would do bicarb. I would do early bicarb. I mean, if I'm PEA, asystole, then you're going to need to give me some epinephrine, right? I just don't pair your epi with your bicarb, right?
Yeah.
What does that do? Makes my epi worthless, okay? So I might as well just give nothing, right? I might as well take my epi and my bicarb and squirt it out on the sidewalk and then give them saline instead. That's what happens if you pair bicarb and epi. You essentially take both of them, you're like, psh, waste it, okay? So space it out. For sure, don't give them right next to each other, but this is a circumstance where I would say that early bicarb is not an unreasonable choice, okay? So what's our indication for ketamine? Excited delirium. This is local protocol, okay? This is local protocol, so take it with a grain of salt, guys that are not practicing in Spokane County. Excited delirium, severe agitation, interfering with necessary patient assessment and or treatment. Your initial dose is 4 milligrams per kilogram IM. Your maintenance dose is 1 milligram per kilogram IV or IO slow infusion over 60 seconds. This is assuming that after your initial dose, you've taken the time to initiate appropriate resuscitation, placed an IV, started fluids. That should be happening on your excited delirium patients. Prepare suction for hypersalivation. That'll happen. Consider Versed for management of the emergence phenomenon that will occur. Yeah.
That can be pushed fast, though, right?
Yeah, that can be pushed fast. Yeah. Full set of vitals, including temperature every 5 minutes, continuous cardiac and end-tidal CO2 monitoring, and get IV access and initiate your crystalloid infusion. Okay, that's the treatment protocol for excited delirium. Got it? So, remember, 50 milligrams per ml, right? So I can give no more than 5 mLs at a single site, IM. Okay? You don't want to give more than that. So if I got a big dude, I might be 2 syringes into it, at which time I might have to like double team them, right? I'll be honest with you, I've never used more than 250 IM on the adults that I've taken care of. I just give them 250. 250 IM. 1 syringe, 1 poke, and that's all I've used. I've never gone to the full 4 milligrams per kilogram. I just go 250 IM. Okay? but the dose is technically 2 to 4 milligrams per kilogram. Going more with ketamine generally doesn't give you a better effect. Once you reach where you need to be, you're where you need to be. You don't get a dose-dependent degree of sedation. Once you achieve that spot, I can't give more to get better dissociation. Once you're there, you're dissociated, you're there, okay? What do you guys give? 2 to 4? So multiple doses sometimes? Yeah, I just generally give 250. But our local protocol is 2 to 4, okay? Where are the sites that I give it and how do I give it? I do a Z-track injection, okay? So I'm gonna pull the skin down, right? I'm gonna pull the skin down where I'm gonna inject, pull it down, inject, and then let the skin come back up. And what that does is it gives me a little bit of a seal. So I pull the skin down, I stab a hole, and then it kind of seals itself over as that skin comes back up. And I can go in several different spots. I can go in my thigh, my vastus lateralis. I can go in the deltoid. I can go actually right here up over the hip bone, right at the iliac crest, the injection site right here. Okay, make sure you're below your hip bone though. You're not like up here in the gut. Okay, make sure you're below that iliac crest right here. Or I can go right back here in my glute. And if I took my butt cheek and I made cut it into quarters, I want the upper outer quadrant is where I'm going to inject. Okay. So if you need to double team somebody, you can get a vastus lateralis and a deltoid, one person on each side, right? Okay.
Are you cool with us just going through like genes and stuff like that? For,
I'd prefer if you would clean the site, aspirate, do the whole 9 yards, but your safety is also primarily important. And you know, and it's been studied and documented that you can safely give it through people's clothing.
Not that I have much experience, but it seems like trying to whistle and have some hands off.
Yeah, so it's a ball. It's a real. Hang on. So usually, so that brings up a good point. Is you need to have some sort of law enforcement presence, right? They're excessively. These cases tend to be in the spotlight. They tend to get reviewed. You don't want to be the cowboy who like tackles a dude and gives him ketamine just because you want to be a tough guy for the day, right? Get the authorities there, right? Do it in a safe environment. It's a brief time of conflict where you can expose the skin if you need to, and if you can't, you can't. Okay, your safety is going to be primarily important there. Okay. You need to communicate with the receiving facility. There's an exceptionally high incidence of intubation in hospitals that receive patients who are getting pre-hospital ketamine. In all the studies, it tends to be like 1 or 2 ER docs in each group that just like intubate all of them, because I think they're not educated on receiving pre-hospital ketamine patients. So part of this process is me educating the ER docs too about we're going to be seeing more of these folks. But I think appropriate communication can help alleviate a lot of that concern. If I got a non-rebreather mask on somebody and they spit all over it because they have hypersalivation, what's that look like when I got a gorked out dude who comes in with a mask full of secretions? He can't protect his airway, I'm going to intubate him, right? As opposed to, all right, he's hypersalivating, but we've got him suctioned. I don't put cruddy stuff on it, clean him up, right? Present them in a reasonable fashion. Like, no, he just had ketamine, he's doing fine. Been monitored the whole time. He's got good SATs, good cardiovascular vital signs, etc. Communicate the use of benzodiazepines because that can result in respiratory depression, and that's something we need to be aware of. Yes.
How soon after are you chasing the ketamine with the benzo?
Oh, I usually, what I'll do is I'll get them to where I need them, to where I can work on them, get an IV, get fluids started, get the necessary stuff that I need, including on the monitor, vital signs, all that, and then I'll consider it. So it's very much a delayed thing. You got 20 minutes to give it. You got 10 to 20 minutes to give it because it's really just there for the emergence component.
And then just the normal, like depending on
Yeah.
person size.
2 milligrams per sec, 2.5, yeah, I think it's reasonable. Whatever the protocol is for sedation.
So with excited delirium, is it kind of like that 10 to 20 minutes, and then after they start coming out,
No,
they're okay? Or do you need to keep
the times that when they wake up, they tend to wake up less amped than they were. Yep. Particularly if you gave them some benzos, and you don't need as many benzos as if you tried to put them down with benzos, right? So you give them enough, they wake up slowly, they tend to stay relatively calm, cool, maybe a little bit of yip yap, you know, some, you know, what have you. But then it's very easy to address that with an appropriate dose of benzodiazepines. But when I'm trying to tackle them and get them to shut the hell up, and I'm giving them benzos, that takes a lot, and it rarely gets me where I want to be in terms of a safe environment to work on somebody and treat them for a potentially dangerous condition.
Are they restrained when they're coming out?
Yeah, I do. I have them all restrained. I get them restrained as soon as it's safe to get them restrained.
How often are they coming out of this still in excited delirium?
Well, they're still they're still intoxicated, so they still have an intoxicant on board. Usually, if it's a psychiatric patient, this doesn't fix their psychosis, right? So they'll still be psychotic. If they're on meth, they're still tweaking, right? But you've taken away this, you've taken away the drive, essentially. This conflicted drive that is real. Once you remove that, it's much easier physiology to control and to manage. So they'll wake up. I usually give them a benzo to slow that process. And then I've got someone who, I just give them another 2. And so, you know, they start to chatter a little bit, 2 more, right? And they start to chatter a little more. And then I can appropriately dose them and not get to a point where I'm like, oh man, I'm like 10 milligrams into it, and this guy's still ballistic. And then all of a sudden, right, now he's not breathing. That's not where I want to be. You can redose with ketamine too if you need to. Yeah. I just use Versed. I've never had to redose ketamine. I've just, maybe in kids I have before when I was doing a procedure or something like that. But in general, for management of excited delirium, I've never had to redose it. And I've done excited delirium on people that, I've done this protocol on people that weren't excited delirium. I had one crazy lady, crazy demented lady, who you couldn't touch her without her trying to bite you. She wanted to bite everybody. And she had a fractured ankle with her foot pointing out like towards her ear. She's like, kill you. Don't touch me. Nobody touch me. Like ballistic crazy, like crazy cat lady down the street crazy times 10, right? So we gave her ketamine because we couldn't manage it. We couldn't address her emergent condition safely. She wanted to bite everybody. So, well, ketamine, she's a tiny little thing, didn't take very much. And we got to do what we needed to do, got her ankle splinted, casted, or reduced and splinted. And then she woke up and it was back to the usual. Don't touch me. That's her baseline, right? But her baseline precluded us from taking care of her emergent condition.
So with Versed, 5 to 10 minutes, and then there's no real max dose if you're allotting that time to pass and you're checking resting for time.
What for which?
So for Versed, so after you give the initial dose of ketamine and you're following up with benzos, what's your time?
Give them 2 at like 10 minutes. Start to wake up, give them 2. Or you could not even give it.
Like you got a long transport time.
Yeah. Once you got all your other stuff taken care of, give them a little slug of small, like not a slug. Give them a little, like 2.5 milligrams of Versed. Just enough to slow things down. But don't let it be, one, if I give it right off the bat, it probably will wear off before my ketamine wears off. You probably still get some benefit. Some people like to do that. That's my personal preference, is to do it, take care of my other things first. IV in, then I can give it through an IV, but I prioritize fluids, I prioritize physiologic monitoring, vital signs, cooling them off, and then redose with Versed. And it's going to be, I can't really answer that honestly because it's just going to depend individual where you're at.
I guess it's a top dose for Versed.
Yes, when they stop breathing, you gave it to them. Yeah. I would do it in your normal. Doses, which I think in the protocol is like 2 milligrams per kilogram, repeated every what? I don't know. I have to look. 2 milligrams per kilogram, 2 to 2.5 or something like that. But they shouldn't require that much after ketamine. They shouldn't require more than what we're generally would like to give somebody. They shouldn't require the doses that are required if they weren't getting ketamine. Unlike most induction agents, ketamine produces a central sympathetic stimulation, so increased heart rate, increased blood pressure. It's great in trauma, right? Really good in sepsis. It can be good in asthma because there's a bronchodilation benefit to it, okay? It has a direct negative inotrope effect. And this is related to the calcium influx in the NMDA receptor. You also get some impaired calcium uptake from the sarcoplasmic reticulum, which is responsible in muscle cells for contraction. So you get a direct negative inotrope. So although my rate went up and my squeeze is better, or my vascular squeeze is better, my cardiac squeeze is somewhat impaired. And for general, normal, healthy cardiac patients, it's not a big deal. But this is probably not the best drug for someone in cardiogenic shock or ischemic heart disease. Someone who's got impaired myocardial function, someone who's a bad CHF patient that you want to intubate, this probably is not the best drug because there is a direct, although there's an indirect sympathomimetic effect, there's a direct negative inotrope, negative squeeze effect. It's directly cardiac mediated, not central nervous system mediated. Some people argue that a smaller dose of ketamine will take care of that, but I think then you get into the complicated situation of half dosing people and double dosing people, and I just don't think that's reasonable at this point. For endotracheal intubation, it's 2 milligrams per kilogram IV or IO, slow administration over 60 seconds. Fast administration causes apnea, right? So slow administration. Always administer the appropriate dose paralytic with it. Manipulation of the oropharynx and larynx can precipitate lingering laryngospasm, so I would not want to use this in someone who I'm going for sedation prior to a blind nasotracheal intubation, right? So the blind nasotracheal intubation, I'm not going to paralyze because I want that person still breathing. That's how you do it. You stick it in their nose, you get it right, hover above the cords. You can see the fogging in and out of the tube, and then you go, you try and blindly insert it. Well, if I tap that thing and I get laryngospasm, I'm screwed, right? So probably not the best thing for blind nasotracheal intubation. Most of that laryngospasm will be mitigated with an appropriate dose of paralytic. So if you're using a paralytic, that shouldn't be a problem. Hypersalivation, have your suction ready, and then follow with an appropriate ongoing sedation, which most of the time will be benzos, okay? Ketamine and analgesia for burn patients, for bad trauma patients. It requires a tiny dose, still has to be delivered slowly. Less hemodynamic instability than opiates. If you're getting to a point with opiates where you're like, man, I'm giving this guy a ton of opiates, I'm starting to get worried, but they're still in pain, this is a nice analog, something else you can administer that could provide you with some additional analgesia without contributing to respiratory depression, okay? And it can be used in conjunction with opiates safely. Don't use it for cardiac chest pain, right? Because it's going to increase my myocardial oxygen consumption. So contraindications, don't use it in people with significantly elevated blood pressure that would constitute a hazard. Flash pulmonary edema, hypertensive emergency, suspected strokes, the blood pressure 200 over 100, right? Now, people who have excited delirium, their blood pressure and heart rate is all elevated, but that's usually because of the underlying excited delirium. If I can get rid of the excited delirium, that'll actually settle down. If I give the guy with hypertensive emergency this, I don't treat the hypertensive emergency, I just add to it, right? So not a good drug for primary cardiac related issues. Avoid it in ocular and globe injuries because it's got increased intraocular pressure. Caution in myocardial ischemia. Caution in patients with VP shunts and hydrocephalus. Caution in patients with schizophrenia, except in the ones that are excited delirium, okay? It's not a wonder drug. There's a lot of fascination about ketamine. A lot of people have wanted it for a long time. Just because we have it doesn't mean that it's like carte blanche, use it on everybody. It's not the perfect drug for every situation. It's got a very defined role of where it's good. I think it's very beneficial in a lot of areas. I think there's definitely an opportunity for it in our system and in the pre-hospital setting, but use it appropriately. All right, anything about ketamine?
Sounds like a wonder drug.
Yeah,
Nice few things, but
that's a pretty good drug.